Tiff,
Wait, one question
Go.
before we start. Are we aiming for
half an hour.
10 minutes? Yeah, 10 minutes each.
Half an hour.
Cool.
Yeah.
Amazing.
Each. That was good. Last time it was good. It was
It was good.
snappy. The sun's out.
Yeah, sun's out. Sam, how are you? Sun's out.
I'm good. How are you? Busy.
Very busy. We'll have another episode about our own ventures soon. But
yeah, good idea.
yeah, for now we'll talk about recent breakthroughs in the medical world from Q1 2026.
Yeah, very exciting stuff. I think we've covered the whole, covered the spectrum. We've got some cancer, some obesity. That's not the spectrum, is it? That's just, that's a tiny part of it. But there we go. That's what we've got.
That's most of the top selling stuff.
That's true. We've got cancer and obesity. How do we do it? Just start?
I say we start with cancer. Let's start with the famous p53 or TP53 gene. So what's going on there, Sam?
p53 I think is definitely one of the most interesting genes, right? So I think we both are people basically who have PhDs in p53, no?
Yeah,
in the biology
do.
of p53.
So yeah, Sam and I did our PhDs together in oncology, and p53, some of you might have learned about this in high school biology as well, but it's known as the guardian of the genome.
Great name.
And it's amazing name. And you published on it. Mm-hmm. You did your PhD on it as well. And, it's when anything goes wrong in your cells, p53 gets activated and basically tries to fix the cell or destroys it if it's beyond the point of no return. And in 50% of cancers, p53 is mutated.
Yeah, exactly. And to talk about some of the things that cause p53 to be activated.
Yeah. Stress in the cells. Like if your cells are replicating too quickly, and it's like, imagine that the brakes on your car are not working and your car is just going and going, which, the system in the cell for that, it's called the cell cycle, which Sam is an expert in.
Used to be.
And what happens is p53 comes in and says, okay, this cell has to die now because it's obviously something's broken, something's wrong with it, and it cannot keep duplicating or replicating, or else it will turn into a tumor.
Yeah, exactly. And I think it's interesting that most of the things that activate p53 are the things that cancers like, right? Or that cancers need. So hypoxia is one, right? Low levels of oxygen is something that cancers have. And that activates p53. Or DNA damage is something that cancers really like because it allows them to accumulate mutations and change things.
Exactly. An acidic environment.
Yes. Yeah. The Warburg effect.
Yeah.
Protein stress, general stress, replicating too fast. All of these things are things that cancers need, right? And
basically chaos.
Cellular chaos activates p53, which is why it's basically impossible for a cancer to form with normal working p53. So in 50% of cases, it's mutant. And in most of the rest of the cases, it's deregulated in some other way.
Exactly. So even when the gene itself is working, even when p53 gene is not mutated, there are some other mechanisms in the cell where it's being suppressed.
Yeah. By
another protein or RNAs or
exactly.
There's so many ways to suppress it.
Exactly. There are over 1,000 ways to suppress p53. And so cancers pretty much always find one of those ways to suppress it.
Exactly. But, people in the cancer field were trying to reactivate p53. And it's really tough because the tumor is really smart. It finds different ways. When you reactivate p53, it'll find another creative way to suppress it. So it's like a race.
It's so tough, right? And I had a look at so reactivating p53 is a fascinating idea in cancer because then you can switch p53 back on and then slow down the cell cycle, as you said, slow down division and also kill the cells, promote apoptosis. And in the history of time, there's been a lot of p53 reactivating therapies tried in the clinic.
But they've all failed.
Absolutely all of them has failed. There actually is one. The very first gene therapy in the history of time was a p53 gene therapy approved in China alone.
I didn't know that.
It was approved in... I don't know, early 2000s, I think, in China alone, never anywhere else in the world. So it wasn't approved in the US or in the UK or anywhere else.
Wow.
And it's like a p53 gene therapy that you directly inject into tumor.
Wow.
and therefore reactivate p53 and therefore kill tumors. Fascinating. But that's the only one that ever got approved. Everything else has failed.
Yeah.
And there's been many, many, many attempts.
And what's the main reason for them failing? I'm sure our listeners are curious to find out.
I think it's because of what you said, right? So like most of the ones that have been tried have been MDM2 inhibitors.
Yeah, so MDM2 is a negative regulator of p53. So when you inhibit a thing that's inhibiting p53, then you're supposed to reactivate p53. But a lot of those have failed because there are other ways aside from MDM2 that the tumor can use to suppress p53.
So if you inhibit MDM2, then p53 goes up, which is good for us, bad for cancer. But then if you just mutate, if you're the cancer and you just mutate p53, it stops working. Because now, right?
Yeah.
Right? So yes. Yeah, exactly.
Yeah,
and then you
exactly.
just mutate p53, and then that's also arguably dangerous because there are some mutants of p53 which not only inactivate it but also have like gain of function, right? So they're actually
it actually
oncogenic.
helps the cancer,
Exactly.
which is crazy.
So now you've got more p53 and you've got mutations that actually drive cancer, and that's where it gets a little bit scary.
Yeah.
So that's why it's such a dangerous gene, but also a fascinating one to reactivate.
Exactly. It's like two sides on one coin.
Exactly.
Yeah.
And that then, so this is a new trial in the New England Journal from a company focused purely on p53, which is a lovely focus, I think, for a company. And they have a gene called inhibitor of p53 called, a reactivator of p53 called Rezatapopt.
Catchy.
And do you know? I had a look earlier. Do you know why it's called Rezatapopt?
Why?
So the last 5 letters are apopt.
Apoptosis.
Apoptosis. So it reactivates apoptosis. So Rezatapopt reactivates apoptosis.
That's so smart.
And it is
finally a drug name that actually makes sense.
Yeah. And it's focused on reactivating a very specific mutation of p53 called so it's a Y220C mutation. So it's the tyrosine at residue 220, which is mutated to cysteine. That's what it reactivates, and what it does, it binds the mutant protein and essentially refolds it.
This is quite a relatively common mutation, right? In p53.
So it sounds niche, right? If you start saying Y220C, it very sounds
what the heck
super niche.
is that?
But it's But it's 1% of all solid tumors have this mutation.
That's a lot of,
which is an awful lot. So it's 1 in every 100 tumors.
No wonder the company went for it.
Yeah, exactly. So yeah, and it like refolds p53 to make it look more wild type.
Yeah.
And therefore reactivates its wild type functions, which are suppressing the cell cycle, killing cancer cells, and so on.
That's smart. And what are they doing differently to, or is that itself a very novel mechanism compared to previous p53 therapies?
So I think it's partly dependent on this particular mutation because usually it's difficult to get a drug in, but this mutation kind of exposes a drug site, like a site,
pocket on the p53 protein.
This particular mutation makes a pocket, which you can then drug, which then they're very clever, much cleverer than me, refold the protein, right? So it's actually specific to this. So if they try to now generalize it beyond this particular mutation, maybe it gets a bit tricky.
But I mean, 1% of solid tumors, so that's so worth it.
Yeah.
And is this a phase 1 study? So it's early in its clinical testing.
Exactly, but the data are super nice, and you can always tell how important the data are by, to be honest, the reaction that there is on like Twitter, and the reaction on Twitter was like
standing ovation.
It's like excited. People are very excited, even though it's only phase 1. So they took patients who had like very, very refractory cancers, so treated with many, many, many different types of therapy, resistant to all of them.
Yeah.
And then they gave them Rezatapopt, and they saw a really nice response. So that's why people were so excited.
That's amazing. So they're already seeing efficacy in phase 1.
Yeah, exactly. So obviously it's not like a controlled study, so you can't say for sure.
But early signs of maybe efficacy.
Yeah, exactly.
That's really exciting. Wow.
Super exciting. Wow. And then I think the only concerns, or some of the concerns with the therapy would be what you raised before, right? Like if
resistance mechanisms. Exactly. What if like it works for a few months and then the cancer comes back because it finds like another clever, cunning way to overcome.
Exactly. So you reactivate this one, but then why not? Why can't p53 just then mutate at a different residue?
Yeah.
Or just upregulate MDM2 or something else to inactivate p53? I think the selection pressure is so strong, it may well happen.
Yeah. Do you know which cancer type they did it in?
Loads.
Or
Like
all
solid
different
cancers.
Wow.
They had,
okay.
but they had all sorts, like ovarian, pancreas, colorectal, all sorts.
Yeah, in my opinion, I think they have to look at it from a cancer type, cancer specific kind of angle and see like, oh, for example, pancreatic cancer uses these resistance mechanisms, and maybe they can do like a dual therapy to kind of predict the resistance mechanism. But
100%. Yeah, you can definitely envision. Sorry, I think maybe you need to go slightly closer to the thingy. Sorry.
yeah, no, you're right.
Just because I was thinking maybe you're going to be very quiet, I think.
Yeah, for once in my life. Yeah.
No, but I completely agree with your point. Yeah.
Hey, well, speaking of pancreatic cancer.
Yes, go ahead.
Unless you have anything else.
No. I think that's Rezatapopt. Everything there is to say about it. Fascinating, though.
So cool. Well, my therapy name is definitely not as hard as to say as Rezatapopt. Is Rezatapopt?
Yeah.
So mine is a phase 3 study that I'm currently focusing on. So this is in locally advanced pancreatic adenocarcinoma, which is a historically neglected cohort within pancreatic cancer, because a lot of trials in pancreatic cancer focus on late stage metastatic settings, which are, also very important trials. But this neglects this locally advanced group, which means the tumor is still localized to the pancreas, but because it's infused or very close to the major blood vessels, people can't have it operated on, so it's unresectable basically. And if you can't resect the tumor out, you're basically left with chemo, and chemo is systemic, has so many side effects, and it's not always effective. So I think for this cohort of pancreatic cancer, the needle has not moved for around 13 years. And right now, the best standard of care for this, LAPAC is the acronym, is gemcitabine, the first chemo, which was introduced in 1997. And then the second one, which is nab-paclitaxel, they say it right, in 2013. And they both affect cell division.
Yeah.
With gemcitabine affects DNA replication by pretending to be, it's a nucleoside analog incorporated into the DNA, but once it gets incorporated, the cell can't replicate the DNA anymore. And then the paclitaxel is basically a microtubule binder, and microtubules are basically like the cytoskeleton of the cell. So you need that for the cell to replicate. So that was last introduced in 2013. And since then, there hasn't been any changes in this LAPAC. Yeah, until now. So in this phase 3 study, this is a breakthrough study because they use a therapy called TT fields, or tumor treating fields. Easy to say. And this is not a chemical innovation. So it's not about, clever chemists making an inhibitor. Here it's more to do with physics, which I know very little about. But they basically try to exert these fields onto the tumor site with oscillating waves, and that also disrupts the replication of the cell by particularly the mitotic spindle during mitosis or cell division. And here, for the first time in, I think, 13 years, there was a statistically significant result in the primary endpoint for this cohort.
Yeah. And it's a wearable device, right? It's just wearable. Like you have to kind of stick it to your skin, and it delivers this low dose these low dose electromagnetic fields like directly to the tumor, which is completely fascinating as an idea.
Yeah.
I don't know any other wearable devices in cancer therapy. I think it may be the only one. It's interesting that it's already approved in a couple of other cancer types. So it's approved in mesothelioma, the lung cancer.
Yeah. And glioblastoma.
Yeah, exactly.
Yeah.
And now it's now approved in locally advanced PDAC,
Yeah.
pancreatic cancer as well. Which is fascinating, and the mechanism is super interesting too. So it seems to like poison mitosis, right?
Yeah, and it also down regulates the Fanconi anemia DNA repair pathway.
Does it?
Yeah,
Is that how it
apparently
works?
it does.
It down regulates the. That's so niche.
Yeah, it is so niche.
I do know what you mean though, but that is very very
it is
niche.
Another thing for my PhD.
So, but that means so if
relevant.
it down regulates DNA repair, then it like sensitizes cells to chemotherapy, right?
Yeah, exactly. So there's
Which is
like
why they give it,
synergistic effects with the chemo.
And I also said also maybe that it seems to be like stimulating immunogenic cell death too.
Yeah, that's right.
So like kind of stimulating local inflammation around the tumor.
Exactly. So one interesting finding from the study was, I mean, wasn't the primary effect they were expecting, but it's an ascopo effect where you have a localized treatment. So they were literally aiming for, near where the tumor is. But they were able to get this distant progression-free survival improvement, which means like apart from like locally like the tumor shrinking or not growing back, there was like a systemic effect, and he thinks it's to do with pro survival inflammation through STING.
Interesting. Yeah. So there's various different ways that it works, and I mean, I think that I just love the fact that it's like a wearable device for cancer, and it's 30 years. My understanding is 30 years. It's the first approved
30 years.
First approved therapy since those old school chemotherapies in 30 years. And as you said, like there's been many trials, but also it's largely been neglected as a field or cancer. And therefore, we just don't know. We just have presumably something works, but we just don't know until now. So it's nice that finally there's a little bit of progress.
Yeah, even though the headlines make it sound a bit modest in terms of
it was a little bit modest.
Yeah, I mean,
but still, it boosts overall. It's very difficult to boost overall survival in cancer. It's really hard, and it does do that. Like with a kind of straightforward wearable device.
Yeah, it's. I mean, people prefer like progression-free survival over.
It's because it's easier to prove.
Exactly. So to be able to use like overall survival as a primary endpoint, it is impressive. And specifically, the stats were the improved median overall survival was improved with this TT fields.
Yeah, what was the number?
To 16.2 months versus 14.2 months.
So it's
basically 2 months.
2 months.
Yeah.
So it is subtle, but still impressive.
Yes.
The company, by the way, is Novocure. I think they're based in Switzerland.
Nice. And they also had another detail saying that patients who completed at least one cycle of treatment, the benefit was even better. So it was a median overall survival of 18.3 months.
You mean with people that had completed a cycle of chemotherapy?
Yes. I think it's let me double check on that. It says a cycle of ITT. Yeah. Let me double check on that. But basically, I think like they're still trying to tease out the different sub effects of like the chemo versus the TT fields and like the long-term effects.
Yeah, super interesting. And just a line on the future of PDAC as well, because it's extremely exciting. RAS, right? KRAS. They're all KRAS. Pretty much all pancreatic cancers are KRAS mutant.
Yeah.
There are
another driver mutation.
0 KRAS inhibitors approved for pancreatic cancer now. Do you know how many, just out of interest, how many are in trials? How many different KRAS inhibitors are in trials in pancreatic cancer right now? Is at least 10. At least 10, and some are in phase 3 as well.
It's really hot right now.
Super hot. There was a paper in Science yesterday where there's a very established precancer state in pancreatic cancer, and the precancer state is also KRAS mutant.
Yeah.
So there's an idea that you might be able to inhibit KRAS in the precancer state before pancreatic cancer to stop, to prevent pancreatic cancer before
prevention.
it starts. That was it. That was
Like
in
a
science yesterday.
vaccine.
Exactly. Yeah.
Yeah.
But it's a drug, like a drug to do it. That was preclinical, but it shows like the direction of the field is going. It's very exciting.
That's where the future of medicine's going. Prevention.
100%. Yeah, for
Precision.
sure.
Yeah.
Okay.
Exciting.
Last one.
All right. So let's move away from cancer for a bit.
Good idea.
What's going on outside of cancer?
Okay, well, obesity is the most important topic in the world right now, right? It's my favorite, maybe my favorite topic. I love talking
it's
about.
Definitely your favorite topic.
So there's some amazing obesity drugs, right? The GLP-1s, and one of the issues with the obesity drugs is that they cause muscle loss, right? So they cause muscle loss as well as weight loss. So people say things like Ozempic face, right?
Yeah.
So, but there's a potential to. So, what the question is, how do we stop that muscle loss but retain the weight loss, right? So, this is a
best of both worlds
trial from Eli Lilly, actually, using a drug called bimagrumab. Bimagrumab, it's like a muscle. It's like a muscle stimulating antibody.
Yeah.
And they added it to semaglutide, and tested whether that could cause you to retain muscle but also lose weight
in a phase 2 trial.
Yeah. And the results are pretty amazing. So the people who took both semaglutide and bimagrumab lost more weight than either alone.
Wow.
They lost up to, and this is insane, they lost up to like 45% of their body fat. 45% body fat with both drugs.
45%.
They lost less muscle than they would have done with semaglutide alone. They had dramatic reductions in CRP, which measures inflammation. So dramatic reductions in inflammation, like 80+%.
That's incredible. But that also makes a lot of sense because you know how I just went to the gym this morning. My trainer always tells me like, oh, when you build muscles, it's also easier for you to burn fat. It's like the synergistic effect. So that's why people who build more muscles, they can afford to eat more because they're burning the fat faster.
Interesting. And it's interesting that even so they had a bimagrumab group alone, right? And those guys lost weight and gained muscle.
It makes sense.
Alone. So, and this is an interesting drug because it was initially tested in patients with muscle wasting conditions, but it's not been approved for anything yet.
Yeah.
But now it's being tested like alongside the GLP-1s.
And it's great because it addresses like one of the biggest side effects of GLP-1s.
Yeah, exactly.
Yeah.
There were some safety concerns with the doublet. So as you can imagine, you put two drugs together, you cause a huge amount of weight loss. So there were some safety events. So like gastrointestinal events went up. People had like muscle cramps as well. People getting acne as well.
Oh,
so there was some adverse events related to this, but so the price you pay is that for like more weight loss, more fat loss, retaining muscle. So, but it's very interesting, right? And you can imagine it as well, to be honest, for like a bodybuilding drug, right?
For sure. I'm just thinking of all like
an aesthetic drug, like cosmetic drug.
Athletes who want to do exactly that, even if you're not clinically obese.
Yeah,
you want to do those two things. Lose fat and gain muscle.
Yeah.
Which are sometimes two things that are opposed to each other,
very difficult to do.
right?
Yeah. And I think this is probably the first time that's ever been shown that you could like lose weight and lose fat and gain muscle.
This
with,
is scary.
Like,
this is going to be a game changer.
Yeah. It's Lilly as well.
Yeah.
It's Eli Lilly drug. So.
And we're going to talk about this in the next episode about their sales for the past year. But yeah, I mean, I want to just put more of my money into Lilly stocks now.
Are they not already overpriced? I think it's all priced in. Do you know what I don't think is priced in though? Novo Nordisk. I bought some stock the other day.
Yeah, I mean they're catching up
because they've been so oversold.
I'm a long-term investor though, so.
Yeah. And yeah, I think the interesting thing about that is that so GLP-1 started as a weight loss medicine, right? And now I think they're becoming like a backbone, like a platform of their own. So you can use GLP-1s and then just add things to them to exacerbate or stimulate or or help them do their effect, right? So for example, you add bimagrumab for retaining muscle. You can add like cholesterol medicines to potentiate the cholesterol effect. Add like liver medicines to potentiate the liver effect.
And you always tell me like from time to time, you're like, obesity increases like the risk factors for so many diseases.
Yes.
And including like inflammation, cardiovascular diseases. So like it's no surprise to me that when you use GLP-1s and combine it with another disease that's relevant to that patient, then you get a synergistic effect.
Yeah, exactly. There's even this one completely insane, you know, I always love this idea of like multi-agonists, like quadruple agonists. There's an insane drug.
What do you write in your Substack? The 3 Ps? The 3 Gs, sorry.
Yeah.
3 Gs.
So there's a triple G, right? There's a triple G. So it's like a retatrutide. It's like a triple G. So it causes insane weight loss. And then some company came along and added a antibody against PCSK9, like a cholesterol drug. So this drug does 4 things, right? It agonizes GLP-1, agonizes glucagon, agonizes GIP, and inhibits PCSK9.
Oh my gosh.
4 in 1. And there's a
3 Gs and 1
P.
Yeah.
And there's an image of this drug, right? Yeah. It's like obscene. This thing looks ridiculous. But it's coming. It's happening, apparently.
How does it get in?
I've no idea.
I was just thinking about the chemistry of it.
Yeah, wild.
It's crazy. Well, exciting times.
It's crazy. It's a crazy future.
I know which biotech I'm putting my money into.
That one. Innovant, by the way.
Oh, is the name of the company?
Yeah, Innovant Biologics, I think.
Wow. Are they based in Boston?
Probably.
Every other one of these.
Yeah.
Wow. Cool. Awesome. Well, thanks, Sam. We'll come back next time and talk about biotech deals and all the drama going on in the pharma world.
100%. Nice to see you.
Yeah, good to see you.
Hopefully we keep the sun.
Yeah, exactly. Cool.
Okay.
Thank you.
Ciao.